A very good evening, EDIC Part 2 aspirants and our honorable faculty. Today's the class is about trauma and burn, and it would be conducted by Dr. Gunadhar Padhi. He is a senior consultant in critical care medicine at Apollo Hospital in Navi Mumbai. His area of interests are as follows: ECMO, CRT, and extracorporeal therapy. Over to you, sir.
So good evening, everybody. My topic is burn and trauma. So I'll cover one by one. First, I'll take the session on the burn injury, and then I'll go to the major trauma. Okay. As all of us know, so severe burn injury is equivalent to the major trauma, and there is a proper protocolized approach for every burn injury patient. And burn injury is considered to be polytrauma unless until proven otherwise. That is the reason whenever we evaluate a burn patient, it should be exactly the same way how we do a primary survey, secondary survey, and others in the trauma patient. So as per the American Trauma Life Supporter System, so the trauma patient to evaluated in the different protocols, in the protocols like A, B, C, D, E approach. So A is for airway with cervical spine control, B is for breathing and ventilation, C is for circulation and hemorrhage control, D is for disability and differential diagnosis, E is for exposure and environmental control. So similarly, we have to go the same way like the severe burn injury. So mostly the cause of the burn injury is associated with smoke inhalation. There can be different types of burns, whether it is a electrical burn, whether it is a burn due to lightning injury, whether it is a burn due to major fire, whether it is a burn due to disaster. So the cause of the burn and the injury depends on the type of the etiology of the burn injury. So mostly the patients with major burn, they come to the hospital. So it can be in addition, there can be a coexistent injuries like particularly when there is a history of blast or explosion, motor vehicular accident, high voltage electrical injury. So that is the reason like same with the primary and the secondary survey, just like the trauma patient. So let's go to the pathophysiology of the burns tissue. So this is something called as the Jackson's burn model. So the Jackson's burn model says that whenever there is a burn injury, basically we find three zones. So if suppose there is a burn which starts from the skin, so the skin contains epidermis and dermis, then there is a subcutaneous tissue, then there is the bone and muscles. Okay, so the burn start from the epidermis and dermis. So in the epidermis, so as per the different zone of the burn injury, so one is called the zone of hyperemia, and second is called the zone of stasis. So and third is called the zone of coagulation. So if we go from the inside to out, like in this figure, like how you see, so the central part, the inside to out in the burn injury, this is called the zone of coagulation, where all the necrosis and there is a severe damage to the your hair follicles and other part of the skin, and this is called the zone of coagulation. So this is the most intense area which is suffered from the burn. Then second part is called the zone of stasis surrounding the zone of coagulation, and third is called the zone of hyperemia. Hyperemia means there is an increased blood flow. So these three zones can be differentiated. So this zone of coagulation, it starts from the epidermis, goes to dermis. It can involve the subcutaneous tissue. It can involve the muscles and bone. So depending on the involvement of this subcutaneous tissue, muscle and bone, bone, the burn can be classified as the major burn and the minor burn. So major burns are the burn injury which involves the muscles and bones and the deeper tissues, and the minor burns are burns which they involve the subcutaneous tissue, the superficial tissue like epidermis or part of the dermis. Okay, so epidermis and part of the dermis. So as per that, sometimes many of them they classify burn injuries grade 1, grade 2, and grade 3. So grade 1 is basically the epidermal burn and the part of the dermal burn. The grade 2 injuries deep dermal burn, which involve the part of the subcutaneous tissue also. And the grade 3 is the deep burn, which involves the muscles and the bones. So these deep burns are the more dangerous. This is according to the depth of the burn injury. So this is called the Jackson's burn model. Sometimes it may be asked in the question. So if you see the pathophysiology of the burn injury, so there can be direct injury and coagulation. That leads to the damage of the tissue, and that also leads to systemic inflammatory response syndrome in distant organs. Like there is a burn in the hands, burn in the abdomen, burn in the chest. So there is a direct injury and coagulation which cause the tissue necrosis and injury to that particular area. And because of the release of the inflammatory substances from that area to the distant organs, the patient can suffer from systemic inflammatory response syndrome, SIRS response. So the SIRS response is very, very prominent if the area of the burn involved is more, and as the more is the percentage of the burns, the patient suffer more from the SIRS or systemic inflammatory response syndrome. So what happens to this when there is a burn to the tissues and the direct injury happens? In those cases, there can be release of vasoactive substances locally at that particular area. So because of the release of the vasoactive substances, there can be lot of inflammation which happens at that local area, and also that leads to release of the chemical mediators. Because of that there is a SIRS response happens in the distant organ like the liver, kidney, the heart, the brain, the blood vessels, and the microcirculation. And because of that, the person suffer from SIRS response, severe SIRS response. Second thing, because of the release of the vasoactive substances and there is a loss of skin barrier, the chances of infections are very, very high. And the person who suffer from major burn injury, the chances of infections are very, very high. Both the superficial skin infections as well as there can be chances of deep-seated infection also because of the migration of the bacteria from the skin to the blood vessels. Also, because of the burn injury, there is a lot of capillary leak which happens, and that leads to increase in the metabolic demands, and that can lead to decrease in the cardiac output because of the exudation and subsequent hypermetabolic state. So the person goes into low cardiac output state because most of the tissues that has been leaked into the third space and the cardiac output goes down, the fluids, the amount of fluid, intravascular fluid that goes down, and to compensate that, the person shows severe tachycardia and hypermetabolic response. There can be also accelerated gluconeogenesis to combat the stress response. And as we know, in all the stress response, there can be insulin resistance, there can be hyperglycemia, and this leads to a catabolic state. So burn injury is nothing but it is a hyperactive catabolic state where there is a rapid breakdown of the proteins and there is a insulin resistance, and that leads to hyperglycemia, and that can lead to diabetes mellitus, stress-induced hyperglycemia. So as narrated, we have to go for the primary survey, secondary survey, and the tertiary survey. As we know, the primary survey consists of airway protection with cervical spine protection, airway maintenance with cervical spine protection, like the trauma patient, ABCDE approach. So the airway, particularly in case of burn, is at very risk of obstruction because there is a lot of swelling in and around the oropharynx and soft tissues of the neck secondary to the burn injury. So all the burn patients are considered to be difficult intubation until proven otherwise. If the burn involves the airway structures or the burn involves the face or the facial structures, the chances of difficult airway is very, very high. And those patients usually sometimes require tracheostomy, and the securing airway is a challenge for them, and they require all the gadgets of airway management, starting from the video laryngoscope to percutaneous tracheostomy set ready, and senior intervention, particularly keeping a surgeon standby and also ENT surgeon standby. And also the second dictum is that sometimes the injury may not be very obvious from the outside. The person may look normal, but actually the extent of the injury from the inside is very, very high. So particularly if there is a inhalational injury. Okay. And in case of inhalational injury, when do we suspect inhalational injury? If the patient was in a confined space at the time of accident, or if you find that there can be a facial burns, or there can be singed facial hairs or singed nasal hairs. So that is an indirect evidence that the burn injury is quite significant. That means this patient is suffering from inhalational injury. If you find some kind of black color soot or mucosal inflammatory changes in the mouth or nose, if you found some kind of black color sputum or if you find that the patient is having change of voice, the patient is already in stridor, there can be intraoral edema. Those are the indirect hint that suggest that this patient is having suffered from severe kind of inhalational injury, and they automatically these patients are classified into all difficult airway patients as a burn patient. Okay, so whenever somebody intubate this patient, he should always kept in mind that even if from the outside the person looks normal, but he is a case of difficult intubation, and the chances of airway injury, airway swelling, glottis edema, and difficult airway is very, very high. So one has to follow the proper difficult airway guidelines while intubating this patient. Then, in which case you intubate such patients? Like what are the criteria for the intubation? So the indication for intubation, in which cases you intubate, consider intubation or securing airway in a burn patient, particularly when the patient is in stridor. So the burn patient, any burn patient who is in stridor is an indication of immediate intubation. And prophylactic intubation prior to transfer, if you feel that the patient has a history or signs that indicate likelihood of inhalational injury and thus possible airway obstruction. So if you feel that this patient needs a transfer to the proper setup before means in the ambulance to a proper burn center, and you find that these patients are in stridor, probably you would need to intubate them and you need to send them before just sending them as such without securing the airway. If you find that these patients are already having a severe swelling of the head and neck, probably better to intubate them and secure the airway before this patient go into severe respiratory failure because of the airway obstruction. Any unprotected airway, or if the patient is obtunded because of the carbon monoxide toxicity where the GCS is going down, or if the patient is uncooperative or disoriented patient, agitated patient, those cases in a burn injury possible, they require the early intubation and ventilation. Okay, so always keep in the mind. The second is the B, that is breathing and ventilation. They require almost every burn patient initially give 100% oxygen. The chances of carbon monoxide poisoning are very, very high. So here oxygen will work as a antidote for the carbon monoxide poisoning. And so when you put them on ventilator, also give them 100% oxygen. Assess the chest. Then see for the deep circumferential burns on of the chest and abdomen. And sometimes you may find that because of the abdomen and burn in the chest, they can have restricted chest expansion, and that can lead to compromise ventilation. So immediate release of these scars, that is called escharotomy, may be required. This is one of the indication of early surgery in case of a burn patient. If you find that the patient is always suspect carbon monoxide poisoning, that I already discussed in any case of the burn injury. Third is circulation and fluid resuscitation. Assess for the circulation, assess for the perfusion. Okay, always assess for the unburned skin color, temperature, capillary refill. See for the pulse, blood pressure, neck vein, particularly the engorged neck veins, and always take good to large bore peripheral IV cannulas. What I mean to say here is that sometimes the IV cannulas or taking a cannulas are very, very difficult, and because of the burn injury involving all the periphery. So if you find that sometimes the neck is accessible, you can take a neck line. If the femoral area is accessible, you can take a femoral line. Sometimes you may prefer to put interosseous lines. So whatever may be, but always try to give fluids, and they require a fluid. Particularly the burn patients, you have to give them good fluid. Then I'll just going to talk about the fluid amount after that. Then fluid resuscitation. So when do you give fluid? Almost every patient of more than 15%, which involve the total body surface area in adult and children, these patients, they require fluid. The goal of fluid resuscitation is to anticipate and prevent the hypovolumic shock. Okay. So what happens basically? So as I have already discussed, it is a severe systemic inflammatory response syndrome, leads to capillary leak, that leads to protein and fluid loss from the vascular space, that leads to decreased intravascular volume and edema of the third space or third space accumulation, and that leads to subsequent inflammatory response. So ultimately, if the burn is more than 15 to 20% of the total body surface area, these are called the major burns. The person land up in hypovolumic shock. So always in a case of major burns, more than 15% of the body surface area, replace them with fluid. Or if you find that there is a significant tachycardia, start the fluid early. There is a lack of evidence regarding the best burns fluid, resuscitation formula and fluid, but what I'm going to discuss is regarding the simplest Parkland formula, which is very simple and which is very effective. And basically it is a crystalloid based formula. So the crystalloids are always preferred over to the colloid, and colloids are better to be avoided. Only in case of large volume of resuscitation we prefer, but whatever the literature suggests, the crystalloids are the fluid of choice, either ringer lactate or balanced fluid solution like your plasma light or Cabi light, or any balanced fluid solution which contains less sodium and less chloride, and which contains more of this buffering substances. Those are the fluid resuscitation of choice. So which is more important is the modified Parkland formula. So what is the modified Parkland formula? It suggests that the 4 ml per kg per body surface area, per percentage of total body surface area burn, that amount of fluid in ml should be given in 24 hours post injury. For example, if the person suffer from 15% of the total body surface area burn and the person is a 50 kg weight, so he will require 15 into 50 into 4 ml. This is the total amount of fluid that has to be given within 24 hours. And half of this fluid should be given within 8 hours. And remaining half of the fluid should be given within the next 16 hours. So suppose the fluid requirement comes to around 2 liter. So the 1 liter has to be given in the first 8 hours, and the next 1 liter has to be given in the next 16 hours. As I have discussed, the Hartmann solution is the preferred IV fluid for replacement. The 4 ml per kg per percentage of the burn surface area is recommended if the patient has an inhalational injury, presentation is delayed, has associated trauma, or has a high voltage electrical injury. So some centers they prefer 3 ml, some centers they prefer 4 ml, but we personally prefer 4 ml. And fluid requirement is calculated from the time of the burn rather than the time of the presentation. Like for example, the person has a burn injury which suffered at 8 o'clock in the morning. He reached the hospital at 10 o'clock. So the fluid requirement has to be calculated from the 8 o'clock to the next day 8 o'clock, not from the 10 o'clock to the next day 10 o'clock. So if the presentation is delayed, for example, if the patient reaches the hospital in 8 hours, in 10 hours, then you have to give aggressive fluid replacement. And those cases you have to give more fluid. So to combat the loss of the burns fluid. Now the most important challenges is how to assess the total body surface area burn. And this is very important because this assessment, if you are able to assess the total body surface area burn, percentage of the total body surface area burn, then you can easily determine the need for the fluid. And also you can decide for the transfer to a specialist burn center. And also based on the total body surface area burn, the burns are classified as whether it is a major burn or it is a minor burn. So any burn area which is more than 15% is considered to be a major burn for the adults, and if it is involved more than 10% in case of pediatric population, it is considered to be the major burn for that particular population. Less than 10% of the burn surface area you can sometimes measure in sometimes means you can manage in the sometimes in not non-specialist burn center also, but more than 10% in pediatric and 15% particularly in the adult, it has to be transferred to the specialist burn center. So there are two types of formulae. One is called the Wahl's rule of 9 and second is called the Lund and Broder's chart. So the first thing, the Wahl's rule of 9 is basically meant for the adult population, and the Lund and Broder's chart are basically meant for the pediatric population. So up to 15 years, you can you apply this formula, Lund and Broder's chart, to calculate the percentage of the body surface area burn. After 15 years, you have to use the Wahl's rule of 9s. So this is called the 9% rule. Very, very simple, Wahl's rule of 9. So basically, as you see in this picture, so you can see the head and neck, any burn which involve the head and neck is considered to be 9%. Both the central trunk anteriorly is 18% and posteriorly is 18%. Each arm is 9%. So this arm is 9%, this arm is 9%. And also the leg, each leg is 18%. So this is 18%, this is 18%. Okay. and the genitalia and perineum is 1%. So if some patient has a burn in the one leg, it is 18%. In the chest, anteriorly, it is 18%. Posteriorly back, it is 18%. Each arm, it is 9%, and head and neck is 9%. So this is called basically the Wahl's rule of 9. So as per this, you can see the majority burn injury, if the patient suffer from burn in the chest and in the abdomen and the back of the chest, then it is automatically this goes into the major burn, because the anterior chest contains the 9% of the burn, 18% of the burn, and the posterior area, the posterior part of the human body, that is also considered to be consist of 18% if there is a burn in the posterior part of the body, so, or the dorsal part of the body. So ventral part of the body 18%, posterior part of the body, if the burn involves the extensive posterior part of the body, that is also 18%. So that is the reason any burn which involves the chest or abdomen or back side of the patient, that automatically means take the patient to the major burn category. Okay. Second is the Lund and Broders chart. So basically this is for the calculated up to 15 years. This is meant for the pediatric population. The figure is here. You can see one is anterior part and second is posterior part. So this is calculated basically in the you can say in the percentage. So in the zero year, half of the head is 9.5%, half of one of the thigh is 3/4%, half of one lower leg is 1/2%. Okay, so this is little bit complicated, so don't go to the details, but mostly if you see the legs here is divided into two compartments, B and C, and also the ankle and the dorsum of the legs, that is also 1 and 3/4. Perineum is 1%, it is 1.5%, it is 1.5%, it is 2%, it is 1%. The central part is highest, that is 13%. So this is how the Lund and Broders chart look like.